Hello everybody, welcome to PCR London Valve 2025. My name is Fabien Praz, I'm an interventional cardiologist from Bern, Switzerland, and I have the privilege to be with Neil Pham, an excellent interventional cardiologist from Toronto in Canada. And our topic of today is a very complex one, Neil, about multivalvular disease, and we will concentrate ourselves on the patient having combined mitral and tricuspid regurgitation. Population that we see more and more and treat as well. So Neil, maybe you can tell us who are these patients, what kind of disease they have, and how do they come to you?
Yeah, great question. So these are patients, typically elderly, who have heart failure, atrial fibrillation. Some of them have coronary artery disease, had previous MI, and they are failing despite medical therapy. They're short of breath, they have peripheral edema, the quality of life is terrible. And they are referred to us sometimes with mitral regurgitation. They may also have tricuspid regurgitation. Our job as clinicians is to figure out what is the dominant lesion and how can we best help them.
So we need to understand better what is producing the symptoms of the patient. Mm-hmm. So obviously for doing this, we need a very careful workup, very careful diagnostic pathway of this patient. Mm-hmm. So what do you do in this patient to find out?
Well, it starts with the basic clinical history, physical exam. You get some idea what's their main problem. Is it mainly left-sided symptoms, right-sided, both? And then we have immediate access to transthoracic echocardiography. This gives you the first clue. From there, we do often transesophageal echo to look at the etiology, determine is this patient better for transcatheter repair, replacement. If they're young, maybe we still could consider surgery. And then after that, at least in our program, we like to do right and left heart catheterization, check for coronary disease, understand hemodynamics, and then based on the decision repair, replacement by the heart team, you may do CT scan.
So CT scan, very important as well. You may do routinely as well CT scan, to be able to look at the anatomy of the patient.
In our program, we don't routinely do CT because, number one, there's access issues. All these patients waiting for TAVI. And then the other issue, of course, is they often have renal dysfunction. We don't want to give them a new problem.
But right heart catheterization, you mentioned, that's something you do in every patient with multivalvular disease?
In all patients, because I think you understand, by understanding hemodynamics, you may understand, is it both valves that are a problem? Is one more the dominant one? You're going to start there. After you can reassess the patient, do you need to still treat the mitral valve after treating tricuspid or vice versa?
So obviously you mentioned surgery as well, very important. If the patient is operable, I think you would go for surgery because both valves can be treated in the same operation at the same time. But let's say our patient is high risk or has any contraindication to surgery. So how do you proceed there in terms of treatment? Where do you start and what do you do?
The conventional approach is if they have severe MR and TR, you start with the mitral valve. You reassess the tricuspid valve after a period of 1 or 2 months. You give the medical therapy a little bit of time to work. Sometimes the TR could improve. There are some predictors of TR not improving, atrial fibrillation, dilated annulus, other factors. In those patients, maybe you're going to see them sooner because you may have relieved one problem, but you have not solved what could be their main problem, which is the tricuspid.
So you would prefer doing this procedure stage at your center, wait for a possible improvement of the right side when you treat the left?
I think if you have a very sick heart failure patient who's in and out of the hospital, or if they're coming from a distance and you're worried you may not see them in follow-up, I'm very happy to offer a combined procedure if it looks anatomically suitable. However, sometimes you do mitral TR and you know the tricuspid cannot be treated with repair, they need replacement. You're going to wait, do a CT scan after time has passed and plan for a replacement.
So very clear, thank you very much, Neil. I think we learned a lot. So complex patient, look at this patient carefully, assess suitability for transcatheter treatment of both valves, and then in your practice, or depending on the etiology, treat one side and wait for improvement of the right side, or do both if the etiology is a primary, for example. So thank you very much for explaining us what to do in this complex population, and see you soon.
My pleasure.